And for some people, that we're going to add a new site to our mini map. For some people, this might be a little bit of a review. It depends on if you came through our introductory course and when you came through our introductory course. So these days, we are only doing CZ baseline recordings in our introductory course. We used to do CZ and PZ, but we quickly realized that that was kind of overwhelming people, so we took it out. And I'm added it to my course. So there's a picture of a cake here, just because if you remember that analogy that we use, like if you try to eat an entire cake all at once, you choke on it. You don't get to digest any of it, and it's not that enjoyable of an experience. But if you can take one little bite at a time, you end up digesting the whole cake, and hopefully it's going to be a much more pleasurable experience. So we will jump into that later. But right now, I just wanted to review this arousal assessment. Also, it's referred to as like a symptom checklist. You should have a digital copy available to you on the website. But one thing you might notice is that this just has 3 arousal categories on it. There's a reason for that, because for the longest time there was only those 3 arousal categories: under, over, and unstable. Ed was the one that figured out about disordered arousal. And we don't really even talk about that one that much in our introductory course, because we don't want people coming to a 4-day workshop and then running out and working with the most complicated, challenging clients right out of the gate. But in my mind, mentally, the minute I meet a client, I'm kind of scanning for any sign of disordered arousal. That's the first thing that I'm kind of on the lookout for. And of course, the 2 biggest types of people that have disordered arousal are our autistic spectrum people and people with early developmental trauma. And by early developmental trauma, we're talking the first 3 to 4 years of life before someone has language. If they had serious physical abuse, neglect, also sometimes just painful medical procedures before this little child is old enough to really know what's going on. They just know that it's painful and scary and distressing, right? Also, sometimes even if a baby is adopted the day it's born and put into the arms of a loving parent, it can be traumatic for that little baby to be jerked away from the familiar sounds and smells of his or her own biological mom, right? So it just depends. Some kids don't develop developmental trauma simply for being adopted, but some kids might. So these are all things to just kind of bear in mind. Also, if a caregiver, if a grandparent who was the primary caregiver dies unexpectedly or dies expectedly, during those first couple of years of life, if a kid is separated through illness from a caregiver, divorce, abandonment, all that stuff can count. Okay, so I'm always looking for anything that might imply that this little nervous system wired itself up in a state of fight or flight. So that's just in my mind. Then the next thing, if I get lucky and I don't have to worry about disordered arousal, the next thing I want to screen for is any of those big 4-starred unstable arousal items. And by the way, some people just hand this checklist to their clients and let them fill it out themselves. I mean, if they're adults. But I like to go through it item by item with my people so they can ask clarifying questions and I can ask clarifying questions as needed. The other added benefit of doing that is that you end up passively memorizing what symptoms go with what arousal category. So it's kind of handy. But I'm gonna break it down for you the way I break it down for my clients. So with unstable arousal, those big 4-starred items, any history of seizure we want to be aware of. But if they only had a seizure when they were an infant and they had a really high fever, that might not be that serious, but we're going to file it away. But of course, if someone has had any seizures recently, then that definitely counts. The same idea is kind of true with head injuries. So if someone had a cerebral event, like a stroke or an aneurysm, of course, that definitely counts. If someone, like I have a client who was a big-time kayaker, and he got trapped under the water for a long time. He actually drowned. They brought him back to life. So his brain was deprived of oxygen for a long time. Of course, that counts. And then bumps on the head, vary on how serious they are. But if it was a good enough hit to the blow to the head to result in a lengthy period of unconsciousness, or if the person had any lingering effects in terms of their emotion regulation, their memory, their concentration, that counts. Also, I think we've mentioned this before, if someone just has multiple concussions, those multiple concussions can add up. So I treat that like a significant head injury. With migraine headaches, you can have different types of migraines. It's an ocular migraine or abdominal migraine or a more conventional migraine with just headache, pain, and nausea. You treat all those the same. And if someone has had one of those within the past 2 years, I'm definitely gonna default to stability training, no matter what the map says, no matter what anything else says. Also, at least to begin with bipolar symptoms or diagnosis. Now, I know that diagnosis gets thrown around a lot these days. We have a psychiatrist here in town who, if it moves, it's bipolar. But what this is really talking about is a true bipolar condition where there's a presence of a manic episode followed by a depressive episode. But I mean, to be honest, if there's just really intense emotion regulation problems, that might be enough to warrant doing stability training. Okay, so those are the big 4 that are strongly associated with instability in the EEG. The other symptoms under the unstable arousal category don't cluster as strongly with instability. They just kind of didn't neatly fall into the other 2 categories. So if someone has a lot on the unstable arousal column, whether or not they're starred, then I'm going to consider that. But let's say they do not have any of the big 4-starred items, and they only have like one of the unstarred items on the unstable arousal, I'm probably going to be more interested in what they're telling me in terms of under and over arousal. But I'll definitely, no matter what, file that information away. Because if you start getting inconsistent results with the same training protocol, or you just have a hard time ever getting, lasting good results, then you might need to add in or switch to stability training. Okay? If we get really lucky and we don't have to worry about either disordered or unstable arousal, which, to be honest, is kind of unusual if you're a neurofeedback provider, because as neurofeedback providers, we often get the most complicated cases because these people are looking for something when other interventions haven't worked out so well. Some of our other people that are not traumatized or have instabilities, they might respond well to other interventions and never find their way into our office. But just the nature of the beast, if you're a neurofeedback provider, you're going to see a high percentage of disordered arousal clients and unstable arousal clients. But anyway, if you do get really lucky and you don't have to worry about those 2 issues, then that's when we're going to try to look and see, does this person primarily seem under aroused or over aroused? And by the way, as we've been talking, Symptoms alone don't tell you the whole picture. Also, the EEG recordings alone don't tell you the whole picture. But when you can combine them, you get a much better idea about what type of training could be helpful for this person. Okay, and it is now some people get confused and they think if a client has equal amounts of items checked on under or over arousal, that means you should do the stability training. Not necessarily. There are some people that do benefit from some left side activating training and some right side calming training together in the same session or sometimes alternating sessions. This is what we're going to try to figure out. Okay. So we keep going. So with the mini maps, if we were meeting together, we didn't have to worry about social distancing and we could meet in the same room and we were doing this class together, this would be the point where we would practice doing the mini maps. And as I said, we would do a CZ eyes open recording and a PZ eyes open and PZ eyes closed recording. Now I know not everybody attending this class, they may not be using eager software. This slide pertains to eager software. I'm not going to spend a lot of time talking about it because not everybody may not be using this system. But for those of you who are, I just want to give you a few reminders. Because, by the way, it's really normal when you're first starting out with neurofeedback to have to repeat these maps on the same person a couple of times because you forgot to do something. That is 100% normal, and that's why it pays to practice with friends and family and people that are going to be really patient for you. But anyway, so when you're doing a mini map in Eager, you create a client file, and you want to select the experimental protocol because that's the protocol that we use for mapping. When it asks you, do you want to do a custom session plan, you can say no. And then when it asks you what layout you want the 14A channel A layout, and then you select default setting. And I just have a little asterisk there for all you eager users, because even though you've gone through all those steps, when you first call up your client file with the experimental protocol for the first time, you're going to map them. You still have to change the layout on your planned session screen. That change layout button is down at the bottom of the screen that has the head picture on it. You change it to the 14A channel A layout because that will give you all these lines of EEG information. The 1 to 4, which is delta, 4 to 8 theta, 8 to 12 alpha, 12 to 18 is a combination of low to mid beta, and 22 to 36 is fast frequency or high beta. And we're actually going to talk about this little 1 hertz bend section a little bit later. But I'm going to tell you what you actually do with that. Okay. So why do we bother doing these mini maps at these particular sites? I always like people to have a rationale for why we're doing what we're doing. So it turns out that CZ just happens to be the best spot to measure general autonomic nervous system arousal. Just as a review, if you remember from biology class, the autonomic nervous system is made up of your parasympathetic and sympathetic branches. So the sympathetic branch of your autonomic nervous system is concerned with fight, flight, or freeze, and your parasympathetic is rest and digest. Okay, so CZ is on the vertex of the brain where the front, the back, the left, and the right all intersect. You get a nice blend of signal there, so it's a good site to measure, to take the temperature of this person's general arousal level. And you can do that by taking your theta to beta ratio from the CZ eyes open recording. We are going to practice doing that later. With the PZ stuff, PZ eyes closed helps you find the person's specific idling speed. That's also known as the posterior dominant rhythm or peak alpha frequency or idling speed. You will hear it referred to all three of those things. Okay, and then also having a PZ eyes open recording and a PZ eyes closed recording and looking to see how those amplitudes change or not under those conditions gives you some important information. It's another important clue about this person's arousal. By the way, I just want to point out that with the PDR or peak alpha frequency, that's looking at the speed of the person's EEG, and then the amplitudes will tell us how well this person idles. I hope my cameras aren't blocking your slides. All right, but before we get into that, this would be the point in the class where we were actually practicing recording these maps and putting the sensors on. So I want to take a few minutes to talk about what every real estate agent knows is the most important thing: location, location, location. So just as a little review, this is a slide of the 1020 map for sensor placements. And you will notice that every one of those little sites on the head has a letter and number combination. So this helps you know where on the head we're going to be. So the FP stands for frontal pole, which is really kind of the middle of the forehead. If it's an even number, even numbers always refer to the person's that you're mapping, the person's right side. Odd numbers refers to your client's left side. Z stands for zero or midline, that imaginary line that runs from the bridge of the nose to the base of the skull. Okay, FP frontal pole, middle of the forehead. F is going to be frontal lobe. T's are our temporal lobes. P is the parietal lobe. O is the occipital lobe. CZ is that vertex, and then C3 and C4. The C's actually stand for central sites, but C3 and C4 are our best guess for where the sensory motor strip might be, too. Okay? And so when we're trying to find these things, I really love this slide because it shows you that some important skull landmarks. We've got the nasion, which is the bridge of the nose where the nose runs into the skull. You have the inion, which is the base of the skull. If you run your thumb up your own spinal cord and you hit the base of your skull, some people have a pretty pronounced indentation right there. Other people not so much, but that's the inion. Okay, if you want to be super precise about your placements, what you do to find CZ is you take a measuring tape. You want to use the centimeter side for all you Americans. I know we're not used to using the metric system, but centimeters will make your life a lot easier. So you use the centimeter side and you measure that total distance from the nasion to the inion. Conveniently, CZ is exactly half that total distance. But if you don't want to measure, it's okay. You can use the quick and dirty way that we talk about, using our fingers and landmarks around the skull. So if you're going to find CZ the quick and dirty way, you got to find the pre-auricular points, and they are a little indentation in the skull right in front of the ear opening. It's not down where the jaw hinges. It's up above that, and if you put your fingers on your own skull and you wiggle your jaw side to side, you can feel those indentations pretty well. Okay, so what we want to do is we want to use our fingers to go. You can put your thumbs on the preauricular point. You put your index fingers on top, on the uppermost part of the head in line with those preauricular points. I always like to double check myself that I'm not kind of going too far forward or too far back by running a line. Hopefully you can see my camera. but by running a line from my finger on the preauricular point up to the finger on the top of the head, if they intersect, then I'm doing a pretty good job of staying in line. But let me stress, that is not CZ. You can see it on this slide pretty well, that if you went straight up from that red dot that's telling us where the preauricular point is, you can see CZ is actually set a little bit farther back. So if you find that uppermost point on the head that's in line with the preauricular point, then you want to go 2 fingers back from that spot. Okay? 2 fingers back would be CZ. And then if you can find CZ, it's really easy to find PZ, because PZ would be basically 3 fingers back from CZ. Another useful landmark is PZ is really the crown of the head. I had one lady that I was working with that said PZ would be where the middle of a yarmulke would be on somebody's head. I'm like, yes, that's true. So if that helps you, that's a great way to remember it. But PZ is 70% of the total distance from the nasien to the inion. If you're coming back from the nose, if you wanted to work your way up from the inion, it's 30% of the total distance, if you want to be really precise about it. But usually, as long as you are clearly behind CZ and you're above the base of the skull, you're probably going to be okay with your PZ measurements. Now, but when we're trying to do the midline recordings, it is really important to try to be on that imaginary invisible line that runs from the nasien to the inion. You don't want to drift over to the left or the right, because then you'd be more in the left or right hemisphere. So people's parts can throw you off, so just be aware of that. You just want to make sure you're in line with the nose there when you're finding these placements. And then let's talk about how you get a good hookup. I can't really help you with the Tinder hookups, but I can help you with the EEG recording hookups. So impedance is just a fancy name for how good of a connection we have. When you're mapping, you really want your impedance to be 20 or below. Now, if you are someone that has one of those UWIZ amplifiers, you will only get one number. If you have another amplifier, you'll get, when you hit Control F7 to check your impedance in eager, you'll get 2 numbers. The top one refers to the signal lead. The bottom one refers to your reference sensor. If only one of those is off, you can just work on the one that's too high. If they're both really high, your best bet is to reapply your ground wire. Sometimes you end up having to redo all 3. That's okay. We just want to try to get as good a connection as we can, because if your impedance is poor, it can distort the numbers you get from your measurements. Okay. We also, when we're attaching the sensors, we've got to clean the earlobes and the scalp with alcohol and NuPrep really well. You also want to use an adequate amount of 1020 paste to attach your sensors. You don't too little, just like the Goldilocks thing, too little 1020 paste can cause problems, and too much 1020 paste can cause problems. So if you have about a pea-sized amount of paste, that's usually pretty good. You also want to do your best to make sure that no hair is caught between the sensor and the scalp, because if it is, that can really impact your connection. So if you want to be like you do when you apply flea medicine to a dog or a cat, when you apply frontline stuff, you got to get all the fur out of the way and apply that medicine directly to the animal's skin. So with our clients, we want to do our best to get all the hair out of the way so we can attach the sensor directly to their scalp. Okay, so those are just some tips for good impedance. So once we get these measurements and we go to the in Eager, you go to your review screen, and then you go and you click on the summary button, and that will call up the numerical record, which we will be looking at in a few minutes. But anyway, this is what we expect those amplitudes for the different frequencies to be, depending on people's ages. Again, you should have a digital copy of this handout that explains the age norms at CZ. These were actually based on people within these different age groups that were functioning well. They slept well, they had enough energy to do the things they want to do. They aren't having problems with focus or concentration. Their mood is good. So these are just norms based on age ranges for people that were not reporting clinical issues. Okay, adults are easiest to learn because they're more consistent. So let's start with the adults. In EEG terms, anybody 16 years and older is considered an adult. Now, granted, in real life, you might have to take someone's maturity into consideration, because if you have a really immature 16-year-old, then they might be closer to a younger teen. But by and large, by the time someone's 16, these norms apply to them. And that goes all the way up to old age, okay? So when you look at the measurements on your review screen at CZ, an adult's theta amplitude should be in the high single or low double digits. You can think of that as roughly around 10 microvolts. Now, by the way, these are kind of loose guidelines. And we when we're starting out, we got to have handholds and footholds to make sense of this data. But just be aware, kind of like my graduate school professor said about theoretical orientations, you want to wear those like a loose garment, okay? But this is gonna at least help us make sense of what we're seeing. So for adults, theta amplitude should be in the high single or low double digits, roughly around 10 microvolts. Alpha, the 8 to 12 hertz activity, should also be really close to the theta in amplitude, in that high single or low double digits. And in a perfect world, the alpha amplitude would be slightly higher than the theta. That might just be a matter of decimal points, but in a perfect world, an adult's alpha amplitude would be really close to their theta amplitude, but it would be a little bit higher. And then your betas are easy, because no matter how you're dividing them up, whether that's 12 to 15, 15 to 18, 12 to 18, 22 to 36, you only need about 5 or 6 microvolts of beta activity. You can probably get away with 7 microvolts. Lots of times our really high achievers, kind of driven people have 7 microvolts of 22 to 36. That's kind of the horse they ride through graduate school on. But the higher in amplitude your 22 to 36 gets above your 12 to 18, the more likely the person is to feel anxious or on edge, especially if that 22 to 36 hertz starts getting up in the double digits and it's higher than the 12 to 18 in amplitude. That's going to be a sign that this person is tense, okay? So if we look at kids, which are defined as 6 to 11 years old, and younger teens, which are around 12 to 15, their theta amplitudes can be higher than adult theta amplitudes. Their theta amplitudes can be in the mid-teens, 15, 16, 17, 18. And of course, the younger the person, the higher their slow wave amplitudes can be. Anything 10 hertz and below is considered slow wave activity. So of course, again, 6 to 11 years old is a broad range of development there. So the younger the kid, the higher their theta amplitude is allowed to be. And for kids and younger teens, it's normal for their theta amplitude to be higher than their alpha amplitude. Their betas might also be a little bit a little bit higher than adults. So they might be more around 7, especially if it's a younger kid, because young kids' brains are really busy putting all kinds of information together. But it should still be in the mid-single digits, no matter how you carve those betas up. Okay? So it's always good to look at the actual amplitudes themselves and kind of compare them to their age norms and just see, is there too much or too little of any of these different frequencies in terms of just the basic amplitudes. But then we also want to, so we look at the amplitudes by themselves, but then we also want to look at these amplitudes relative to each other. Okay, and one more thing. So on these mini maps, sometimes we don't pay as much attention to the delta measurements, because with our little thin wires, they can move just with normal respiration. They can move if someone walks behind the person that's getting mapped, or even if the air conditioning comes on, a vent, and if those little wires wiggle, that's going to create some movement artifact that shows up in the low delta ranges. So that's why we don't always look at those things. But just to fill you in, delta amplitudes should be really close to theta amplitudes. If someone's delta amplitude is way larger than their theta amplitude, it's usually because there's just some artifact in the signal, or the person could be chronically sleep deprived, or they might have a history of a head injury. Those are the things that make your delta amplitudes go up. When people get quantitative EEGs, they use much thicker wires, and there's all these precautions put in place to make sure the delta measurements are a little bit more accurate. Okay. But I wanted to give you important information about theta. If you came through the introductory course, you might have had the idea, which is true in some cases, that excessive theta means under arousal. Well, to be honest with you, I have stopped equating theta with under arousal, and now I think of it in terms of too much of an inner focus. But there could be different reasons why this person has too much of an inner focus. And let's talk about what we mean by excessive theta. So when things are going well, then you're allowed to have a certain amount of theta showing up on the surface of the brain. We just talked about it. So it can be in the high single or low double digits for adults. It can be in the mid-teens for kids and younger teens, right? But if you're picking up way more theta than those age norms, it's going to be because of one of two reasons. Either the person's cortex is kind of asleep, it's under aroused, and theta activity is stage 1 sleep, right? Or it could be because the person's limbic system is way over aroused. So our limbic structures are subcortical. They're below those outer lobes of the brain, and they operate in the theta range, Theta. So if they are wildly overactivated, they can break through the cortex's ability to inhibit that. So if you're just looking at the numbers alone, they may not tell you why this person is kind of stuck inside their head. Is it because their cortex is asleep, or is it because their limbic system is overactivated? Well, if you know beyond a shadow of a doubt that they have a history of developmental trauma, we're going to assume that the excessive theta is coming from their limbic system, right? So that's where the person's history really helps you out. Also, symptoms, like if they have a ton of anxiety and a ton of overarousal, even though their theta is really high, that might be coming from their limbic system. Also, with our autistic spectrum people and our developmental trauma people, sometimes the presentation, like I have a trauma, I'm sure you do, I'm sure you have similar clients, I have a person who was so traumatized, she just in the waiting room looks like a deer in the headlights. She's just on high alert all the time. So that's certainly a clue. Also, our autistic spectrum people sometimes, present a certain way. But what we are wanting to determine when we see excessive theta, is that because their cortex is asleep, or is it because their limbic system is way over aroused? That's another piece of the cake that we're eating. Okay, those of you that get a little bit nervous about ratios or percentages, I'm one of those people. I just wanted to show you a visual to help you kind of make sense of it. And let me just orient you to this graph. So the vertical line of this graph is microvolts. So that's going to reflect the amplitude. The height of these different lines show us the amplitude. The color of the lines correspond with frequencies. And on this graph, the violet, purplish colored line is the theta. And then the blue line down at the bottom is probably 12 to 15. And then the red line is the 22 to 36. Okay. And then, the horizontal axis is elapsed time. So you can see that there is way more theta amplitude relative to the betas, right? So if those betas were roughly coming in around 5 microvolts down there, then if that person, let's pretend they were an adult, that person should have a theta to beta ratio of 1.5. So if someone had 5 microvolts of beta, their theta, T-H-E-T-A, should be closer to maybe 7.5 or 8, right? This person has 20 microvolts of beta. So then it becomes our job to figure out, why is this person stuck inside their head? Is it because their brain is asleep and they're daydreamy and spacey and they're paying more attention to what their mind is generating than what's going on around them? Or is it because their inner alarm bells are going off? And just a quick example, this was really brought home to me one night when I was dead asleep, and all of a sudden my smoke detectors went off. It was because there wasn't a fire. It was because the batteries had run out. Okay, so it was so painfully loud. And so I'd woken up out of this deep sleep. So I was trying to even figure out what the heck was happening. And then I had to go get, a stool, and I'm trying to take the batteries out just to make the sound stop. Well, I got all the batteries taken out, but the alarm bells were still going off. And I could not even gather my thoughts. It was such a loud, obnoxious, overwhelming sound that it took me a while to figure out, go to the circuit breaker box and flip the circuit to cut the power, because they had, emergency electrical backup. So, but it really brought home to me, that was an actual physical alarm outside of myself going on. But what if you had internal alarm bells that were that distressing? That would really consume your awareness. There's no way under those circumstances I could have paid attention to someone lecturing me about math problems. And if your inner alarm bells are going off like that, it's also going to be really hard to focus on anything else or pay attention, right? So I just wanted to point that out. So and I did try to look for an example of a normal theta to beta ratio, but I couldn't find one in my client files. So I'll keep looking. Anyway, here are the age norms for the theta to beta ratios. You also have a handout of this slide available. So, and what I did was I just memorized these. It's not that hard. It's 3 sets of numbers. So kids 6 to 11 years old, their theta can be 2.3 times their beta in amplitude. For our 12 to 15-year-olds, they can be 1.8. They can have 1.8 times the theta as beta. And for everybody 16 years and older, the theta to beta ratio is 1.5. And again, these are kind of, rough guidelines. If the person is really close to the expected norm, I'm gonna have to really look at their symptoms and try to figure out, what's going on and what kind of training will be best for them. But if, the farther away their theta to beta ratio is, then the more confident I am about what needs to happen. But I want you to be aware that drowsiness can elevate the theta to beta ratio. So if someone was just really sleepy on the day you took the map, that might make their theta to beta ratio look elevated when really they were just kind of sleepy. Also, muscle tension, if someone's sitting there really tense, that's going to suppress their theta to beta ratio. I'm going to show you a picture of that. Okay, so this is someone, so again, the red line on this graph is the 22 to 36, the fast frequency beta. The purple line is the theta, the blue is the beta. So they're much closer together. But they're probably below a 1.5 ratio. And that fast frequency beta is so high. I know that this person has, is sitting there tense. Okay, so that's an over arousal picture example. Say something else about that. Hang on. Hopefully it'll come back. Oh, yes. Okay, so whenever you are going to map someone, it's a good idea to ask them, is there anything unusual about today? And I stole that right from Ed, because I used to ask people, is today a pretty typical day? And this is why I'm not a lawyer, because that question kind of leads the witness. And if they're an agreeable person, they're going to say, yeah, okay? But we want to know if there is anything unusual about this day. Like if they did not sleep very well, and that's unusual for them, or if they had way more caffeine than they normally drink, or if they just had a horrible, fight with their spouse. If there was something really unusual that could impact these measurements, we just want to wait for a more typical day. It doesn't have to be their best day. It just has to be a typical day. Okay, so I wanted to stress that. All right. So let's talk about how you find the theta to beta ratio. So the way in Eager, the way that you find this record is you would call up the person's experimental protocol from your client list after you've taken these measurements. You go to the review sessions tab, and then it will call up a graph. But you want to go towards the middle of your screen, towards the right-hand side, and click on the summary button, and then that will call up this numerical record. Again, let's just orient ourselves. So you can see that the site says CZ minus A1. By the way, I might have forgotten to mention that A1 is the left earlobe, A2 is the right earlobe. And it's just convention when you're doing a map to reference to the left earlobe. You can reference to the right earlobe, but just be consistent. So if you are going to repeat a map on somebody, you want to be referencing to the same side each time you take the map. I just use the convention of referencing to the left side. Okay, so CZ minus A1, and then we have our frequency list, and our typical frequency ranges are highlighted in that red box. To find the theta to beta ratio, you go to the 4 to 8 hertz range. That's our theta range. You look at that amplitude. In this example, the amplitude is 12.3. So average stands for average amplitude of that column. And then you divide that theta amplitude by their 12 to 18 hertz amplitude, which in this example is 10.3. Now, I'm not great at math, but I know that's 1.2. Okay, so no matter how old this person is, no matter how old they are, that is a low or a suppressed theta to beta ratio. And if we use that information we just found out about what those average amplitudes should be. So their theta is kind of in the high single, low double digits. It's not far off from roughly around 10 microvolts, right? So we're okay there. The alpha, if this is an adult, the alpha is a little bit low because it should be really similar to the theta, if not a little bit higher. We're not quite making it there. On its own, the alpha looks fine because it's high single, low double digits. It is exactly 10 microvolts. It's just a little bit low relative to the theta, and it's definitely low relative to the beta, right? Because the alpha is actually lower in amplitude than the beta, and this person has double the amount of 12 to 18 hertz that they would need if they're an adult. If you're an adult, you only need 5 or 6. This person has 10.3 microvolts of beta. So beta is activation. That's activating brain waves. Theta, you can kind of think of resting. We know sometimes it's actually coming from the limbic system. But anyway, if you're looking at the proportion of slow wave to fast wave, this person proportionately has too much faster wave activity relative to the slow wave. I hope that makes sense. So I can also tell you that this person probably is thinking, problem solving a lot, and they might be the kind of person that has a hard time just listening to something without sitting there just trying to figure out everything they can figure out about this incoming information. They're trying to apply it to everything else they know or to certain situations. And then lo and behold, they might miss the next thing that the lecturer says because they're busy trying to figure all that stuff out. Okay, but chances are that someone with this EEG measurement would have more symptoms of over-arousal because their theta to beta ratio is below 1.5. I hope that makes sense. But anyway, that is how you find the theta to beta ratio. And you can find that anywhere. It's just doing it at the CZ site that gives you an indicator of their general arousal level. So we could say generally this person seems to lean more towards over arousal because they have more activation relative to slowness. All right, and then let's talk about this other piece of information we're going to get by adding PZ recordings to our mini-map. So again, that's going to help us determine the peak alpha frequency, which is also known as the posterior dominant rhythm, or PDR. Okay, and here's this slide again. I love it. So, ordinarily we say alpha is the 8 to 12 hertz range, but truthfully, each person has a specific idling speed that is their own idling speed. If you're at least 8 years old, your idling speed probably will be somewhere between 8 to 12 hertz. If you're younger than that, it might be slower than that. And some people their alpha might actually be closer to 12 or 13. Well, why is this even important to know? If you can identify someone's actual idling speed, it's like knowing where north is on a compass. When you can find north, you can find east or west. Okay, and honestly, most adults idle somewhere around 10 hertz. So even though we say 8 to 12 is the alpha frequency range, most adults idle right around 10 hertz. And engines idle too. Some engines idle a little bit faster, some engines idle a little bit slower. Engines have their own unique idling speed, and brains do. Okay, but if we know that the person's idling speed is 10 hertz, technically their beta starts at 11 hertz, and their theta would start at 9 hertz. Okay, but we don't, even though most adults idle at 10 hertz, when we're trying to reward in someone's low beta range, we don't cut it quite that close. We give them a little bit of wiggle room. And even though most adults idle around 10 hertz, we'll define the low beta as 12 to 15 and mid beta as 15 to 18. If it looks like your client idles at 9 to 10 or 10 to 11, you are usually pretty okay using 12 to 15 for your low beta range, 15 to 18 for your mid beta range. It's if the person idles slower than that, so if they idle closer to 8 or below, then we're going to need to shift those frequency ranges down a little bit. Because if someone idles at 8 and you're trying to calm them down and you use a 12 to 15 hertz reward, then that could end up being over-activating for the person. On the flip side, let's say that someone idles closer to 12. If you were trying to calm that person down and you use 12 to 15 as your beta reward, that might sedate them. That might under-arouse them a little too much, because we don't just have low beta in for that person. We have a little bit of their idling speed in there. Okay, so being able to identify the idling speed sometimes helps you skip a step for having an incorrect reward frequency and triggering something unwanted. So that idling speed helps us kind of tailor our reward frequencies more to the person. I want to tell you a little bit about more about the PDR. So it is most evident in the back of the head with the eyes closed, because it is the idling activity. Healthy brain cells are supposed to fire and then idle. It's like they work, take a break, work, take a break. Some people's do take that break, some people's don't. But it's most evident in the back of the head with eyes closed, because a lot of our brain cells in the back of our heads are devoted or involved in processing visual information. When you close your eyes, they don't have as much to do. So a large proportion of those brain cells should take advantage of this opportunity to take a little break and should start idling. I also just want you to know that people's PDR, or idling speed, matures with age. So when you look at that little cute sleeping infant down there in the lower left-hand corner of the screen, newborn infants, EEGs, idling speed is in the delta range. Their brain is brand new and it's undifferentiated. So their behavioral repertoire is a little bit limited to sleeping, eating, crying, smiling, excreting, right? And they spend a lot of their time sleeping because their EEG idles in the delta range. Well, then by the time someone's a toddler, their idling speed has moved up into the theta range. But what do we know about toddlers? They have rich imaginary lives. They have monsters under the bed and imaginary friends, and they love playing imagination games because their EEG idles in the theta range, which is more of an inner focus. They have these rich inner lives. By the time someone is 8 years old, usually their idling speed has reached at least 8 hertz. Some kids might meet that milestone earlier, and some might meet it later, but by and large, most people by the time they're 8 years old have an idling speed of at least 8 hertz. Okay, that's kind of convenient and easy to remember. And then it does not, speed up in lockstep with ages after that. That's just the one thing. 8 years old, 8 hertz idling speed, at least. Then it will continue to speed up until someone is around 16. And by the way, the brain is differentiating. So it goes from that undifferentiated infant state to the differentiated, starting to differentiate with toddlers and young kids. And then by the time you're 16, now your brain is going to start working on integration. And integration will continue the rest of your life unless you're lucky enough to reach old age, in which case disintegration starts to occur. We want to stave that off as long as possible, But anyway, that your PDR, your posterior dominant rhythm, reflects the developmental health of your brain, When neurologists do a medical EEG, that's one of the first things they look at. They want to see if the PDR is consistent with the person's age. When people start to develop dementia, their idling speed slows way down. But short of an unfortunate illness like dementia or taking certain medications that can slow your idling speed down, the anticonvulsant medications can do that. Your PDR will be what it's going to be once you hit age 16 for the rest of your life until you get really, really, really old. All right. I know we're running short on time. I just wanted to hopefully people can stay to finish this. If you can't, hopefully you can watch the recording. I do want to try to get through the rest of it. But the other reason why alpha is important is because it plays an important part in this creation of our virtual reality. Okay? Because your thalamus is the sensory switchboard, if you remember that. And the thalamus kind of operates like an f-stop lens. Remember how we talked about your brain taking information from inside and outside your body to organize it into a perception? Well, the thalamus kind of opens and shuts, kind of like an f-stop lens on a camera, to take in sensory information. And then let me back up. Some people who have faster idling speeds, that's like having a highly pixelated camera. They're sampling their environment more often and getting maybe a clearer picture from more bits of information. People that have a slower PDR or slower idling speed, they might not think as quickly on their feet. It really doesn't have anything to do it doesn't say anything about their intelligence. It just means they may need longer amounts of time to kind of put their ideas or thoughts together. But with enough time, they could come out with something brilliant. So people with faster idling speeds, they tend to have a good verbal memory, but they also tend to be a little bit more prone to anxiety. I guess maybe if they're getting a clearer picture, they can see more of the possibilities, right? Those are kind of loose correlations. But this is why we joke that if you're ever on trial for murder, take a PZ recording of your defense attorney, because we want one with a fast idling speed so they're going to think quickly on their feet. Okay, and your specific alpha, your specific idling speed becomes like a drum beat that the rest of your EEG organizes itself around. Okay, so it helps time the rest of your EEG. Again, all that information is coming from inside and outside your body. It's sent to the back of your head where it's organized into a perception. So as long as your thalamus is sampling your sensory world and getting an "it's okay" message, it's okay, all is well, then it will keep creating alpha, and you will have alpha in the back of your head there. The minute that your nervous system picks up something that it thinks you should worry about, your alpha amplitude will go down and beta will kick in, because then your nervous system is mobilizing you for fight, flight, or freeze. Okay, so that's why we want an adequate amount of alpha in the back of your head. If we do have an adequate amount of alpha amplitude in the back of your head, that means you're feeling safe enough in your current environment to get "it's okay" messages. Some people so a lot of our traumatized people that have been through really painful experiences, at the end of last week's sessions, we talked about how alpha is sensory gating activity, and some people that have had a whole bunch of painful experiences kind of slam that gate shut. So they kind of suppress their alpha amplitude. That takes a lot of energy to kind of block unconscious material out of your awareness. It's kind of tiring. And it keeps the bad stuff out, but it might also keep the good stuff out. So we want to oil that gate to make it open and close more reasonably, flexibly. We also don't want that alpha activity to be thrown. We don't want that gate thrown wide open, because that's like that I Love Lucy episode when they go to the candy factory and she and Ethel go to the candy factory. And at first, the conveyor belt that's feeding them the chocolates is moving at a reasonable pace, and so they're able to wrap the candies in their wrappers. But then they speed up the conveyor belt, and it's coming too fast, and they're trying to cram all those. They can't possibly wrap them all, so they're cramming them down their shirts and in their hats and in their mouths. Okay, so people that have way too much alpha in the back of their head. That's like, especially with their eyes closed, if their alpha amplitude is too high with eyes closed, that can be a sign of hypervigilance. It's like they're throwing their sensory awareness gates open. They're trying to pick up any possible sign of danger, especially when they close their eyes and one of their main defense mechanisms, vision, is taken away. Okay. So to find the PDR, you want to look at the EEG measurement, the PZ eyes closed recording. We want to look in this little 1 hertz bin section. And by the way, the 6 to 7 and 7 to 8, that's really there for people that work with kids younger than 8 years old. If you have an adult that is, functioning pretty well, they graduated high school, they went to college, they're working at a professional job, they will not have a PDR of 6 to 7. Sometimes it might look that way, but I guarantee you it will be because when you look up in our typical frequency range part above this red square on the slide, it will be because their theta amplitude is way higher than their alpha. So that can skew it. It can look like their PDR is lower than it is. But anyway, to find the PDR, you look for the frequency that has the highest amplitude. But since we're looking for peak alpha frequency, their PDR is actually the speed, not the amplitude. The amplitude just helps us identify what their idling speed is. So in this example, when we look at the amplitudes in the 1 hertz bin section, 8 to 9 and 9 to 10 are clearly the highest. They're higher than the other ones. Technically, 9 to 10 has the highest amplitude of 10.5, but 8 to 9 is really, really close to that at 10.2. We could probably be safe by saying this person idles somewhere between 8 to 10 hertz. It might be closer to 9. 9 is in between, it's common between them. Sometimes there will be one frequency hertz range that really stands out higher than the other ones. Sometimes it's going to be 2 that are really close together. Okay, but anyway, that's how you find the PDR. There it is, 8 to 9, 9 to 10 there. Okay, and the other, just as a reminder, this is looking at frequency. We want to find the speed that has the highest amplitude, and then that speed is their idling speed. And when we go back up to the normal frequency ranges, seeing how the alpha amplitude changes from eyes open to eyes closed gives us a clue about their arousal. So if you're an adult, your alpha amplitude should go up at least 50% when you close your eyes, if not double. So let's just say, if you can have 10 microvolts of alpha as an adult with your eyes open at PZ, then when you close your eyes, your alpha amplitude should go up to 15 microvolts, if not 20. Well, in this example, and by the way, this first set of numbers is a PZ eyes open recording with the frequency, the average, the standard deviation, and the CD. And then that second set of numbers is the PZ eyes closed recording. I'm interested in looking at the 8 to 12 hertz. So if this person had 6.3 microvolt of alpha at PZ with eyes open, then what I'm going to do is I'm going to take 6.3, divide it by 2, come up with 3.15. If I add that back into 6.3, this person's alpha amplitude should have gone up to 9.45 at least, if not go all the way up to 12.6. Well, they didn't make it, right? They didn't make that benchmark. So I know a couple of things. I know that this person wasn't idling very well, at least not at the time of this recording. And this person might just have a busy brain and have a difficult time shifting gears. I actually know whose EEG this is, and I know that they actually have developmental trauma. Is a domestic violence situation that this person witnessed when they were very young. So anyway, so that's an example of kind of slamming that gate shut and maybe not idling that well. Now, if that alpha amplitude had gone all the way up to, well, I don't trust my multiplication skills. If it had gone all the way up to 18.9, if it more than doubles and if it approaches tripling, that can be a sign of hypervigilance, again, of letting all that sensory information in to make sure that no one's sneaking up on them. Okay, so with that Goldilocks principle, you don't want the alpha amplitudes at PZ eyes closed to be too small or too large. So this slide sums up what we just talked about. So when your eyes are closed, the alpha amplitude should increase 50%, if not double. There's the numerical example there. And if the alpha doesn't increase at least 50% with eyes closed, that can be a sign of overarousal. Here's a little clue too. If the alpha amplitude decreases with eyes closed, that's a potential sign of trauma. I have a little asterisk there because that's only true as long as you know your client wasn't getting sleepy during the recording. Because as someone starts to drift off to sleep, their theta amplitude will go up and their alpha will go down. But hopefully that would be fairly obvious if you looked at their body language about whether or not they were getting sleepy. But if you know they actually looked kind of tense, and when they close their eyes, if their alpha amplitude goes down, that's a sign that they've experienced some trauma in their life. Okay. Also, if you're dealing with a kid younger than 8 years old, it might not be their alpha that goes up when they close their eyes. It might not be in the 8 to 12 hertz range. It might be in the theta range, depending on where their actual idling speed is. If their idling speed is in the theta range, then their theta amplitude should go up when they close their eyes. Okay? But if you're dealing with someone 8 years old and older, it's going to be their alpha amplitude that should go up when they close their eyes. But just real quickly, sort of the steps for interpreting a mini-map. You definitely need to know your client's age so that you can compare them to the appropriate norms. Then I always look to see if there's any possibility of disordered arousal or the big four starred unstable arousal, because you got to tell that from their history and symptoms. But if that's the case, we're going to take some special precautions with our training. But if you don't have to worry about that, then we're going to look at CZ, and we're going to look at the average amplitudes by themselves to see what they tell you. Do we have too much or too little of any one frequency? Then you can also calculate your theta to beta ratio at CZ and put that together with whatever symptoms they're reporting. You want to look at PZ eyes closed recordings to determine their PDR to try to figure out what their low beta range might be or mid beta range might be. You also want to look at how the alpha amplitudes change at PZ from eyes open to eyes closed. Do they increase at all? Do they increase too much, or do they go down? Because those are just important arousal clues. Okay, so that is the all that I wanted to talk about tonight. I can stick around if there's any questions anybody has. I know that was a lot.
I have a question.
Sure.
Actually, two questions. One is about the PDR piece. So, from what you are describing initially, it felt like PDR is kind of like a more or less consistent for any given person throughout their life after they are 16, and except for when their eyes are closed. Yeah, okay. So it's pretty much consistent. So what I'm trying to get is when we are training the brain at whatever protocol that we choose, is it going to change the PDR for them over time?
No. That's a great question, and that comes up a lot, but usually no. Now here's the thing: if you are working with a young kid, their PDR may change over the course of training just as a result of maturation.
Yeah.
Okay, but short of that, it is hard to change someone's PDR. And like Ed says, it might not even be advisable to change someone's PDR. It is possible. They have proven that it's possible, and I think this was with college students. And they were doing this brain brightening where they were trying to speed up their PDR. But in order to do that, you had to train really hard, long, frequently. And as Ed says, it might not even be desirable, because if that is the drumbeat that your EEG has gotten used to organizing itself around, it might be really disruptive to change someone's PDR. And it's difficult. It's time-consuming and expensive. So, yeah, go ahead.
So in that then, when we are training whatever the protocol that we are choosing, the goal that is related to PDR then is more about how it's changing when eyes are closed, like how PZ recording is changing when eyes are closed.
When you look at the amplitude of how the alpha changes, that's an arousal clue. But knowing the PDR, knowing their idling speed, can sometimes help you pick a reward frequency that will work better for the person.
Gotcha.
Right? So like that slide, let me go back real fast. So if they had a slightly faster idling speed, like it looked like they idle from 11 to 12, we might, and let's say we're going to train them at C4 minus A2. Instead of using 12 to 15 as our beta reward, we might need to shift that up to 13 to 16. Okay? Because if they idle at 12 and we're trying to reward their low beta, if we use 12 to 15 for our reward, then that might actually under arouse them. They might feel like they had too much wine, right? And on the flip side, if they idle right at 12 and we reward them at 12 to 15, they might feel under aroused by that reward frequency. They might feel better at 13 to 16. On the flip side, if someone idles at 8, or let's say you have a young kid who idles at 7 microvolts, and you were trying to calm this kid down, if you use 12 to 15 as their low beta reward, they might end up bouncing off the ceiling, because that would be more like their mid beta reward. Because if they idle at 7, technically their low beta starts at 8, right? So we would need to shift those frequency ranges down this arousal continuum to get into their low beta. Does that make sense?
It does. Thank you.
Okay. Anything else? I know we're over time. I want to be respectful of people's time, but if anybody has any questions, I will answer.
There's a question there from Jennifer Perkins. I don't know if she's on and wants to clarify. She writes, maybe we will get into this later. Please ignore if so. When somebody with ADHD is focusing, delta increases. I wonder how you describe their task to them when you're doing the mapping, i.e. ensure they're not trying to focus, they're just sitting.
Yeah, they're not. So yes, I mean that's a good point. So whenever I'm mapping someone, I say you don't have to think about anything in particular. You don't have to try to do anything. You just have to be, because we're just trying to take a snapshot of this person's brain while they're not busy doing anything. And I'm so glad that you said that, because on those age norms, on that age norm handout that I gave you, that is based on resting activity where someone's awake and alert, but they're not engaged in a task. So when someone is doing neurofeedback, that's a task. So we actually want their slow wave values to be a little bit lower when they're training than they were on the map, because we want more brain cells working when they're actually doing a task. So that's related to your question, but yeah, I just don't, I just tell them, you don't have to do anything in particular, just be yourself. Just let your mind go where it goes, and we're not trying to do anything. We're just taking a snapshot of your brain in this moment on hopefully a pretty typical day with nothing unusual about that day. Anything else?
May I have one more question? This is next.
Sure.
So going back to theta to beta ratio, so it makes a lot of sense when you say it might be higher because under-arousal, because of an under-aroused cortex or over-aroused limbic system. That kind of made me think when we, in general, in neurofeedback, when we are talking about under-arousal or over-arousal, do we refer to more cortex? Is that the reading that we are getting?
Yeah, we're getting the reading off the surface of the
cortex.
brain.
Okay.
Right.
Okay. Okay. I just wanted to clarify that. Thank you.
Yep.
It looks like Kali has a question if there's time.
Okay.
Hi, Gary. Nice to see you. So I'm still trying to figure out for a family member. I don't think they had any severe early childhood stuff. More, I mean, in terms of, in infancy, but more towards like the age of maybe 6 or 7, difficult kind of neglect and things like that started. And they have like a lot of severe emotional kind of dysregulation. And I've been, training at C3 minus C4, but I'm wondering if there could be disordered arousal even coming from like later childhood stuff.
I think so, because in my way of thinking, 6 to 7 is still really young,
Yeah.
and that brain is still wiring itself up and developing. So I would consider, I would definitely consider that disordered arousal. And next week we actually talk about the special protocols for disordered arousal.
Okay, great. Thank you.
Now, some people might have too much theta and not have developmental trauma, but be over aroused. I mean, so this is why you have to put what the numbers are telling you with the symptoms and the history. Okay, because some people are just over aroused. They're listening to anxiety-provoking thoughts all the time, so their awareness is more inside, paying attention to those thoughts, and those thoughts are stressing them out. But if their childhood was relatively safe, predictable, nurturing, warm, all that stuff, then they might be someone that maybe needs a little bit of right side training and a little bit of left side training, or sometimes just right side training, because we will be inhibiting theta activity no matter what, right? So sometimes just doing the right side training can help them be more present, and that's all you need to do. This is complicated. This is why we're going to take one bite at a time, and we're going to try to be detectives and figure out what their nervous system is telling us that it wants or needs.
Yeah. Okay.
Yeah.
And just another quick question: it can say something like domestic abuse later in life. Can that also create disordered arousal, or is it?
It wouldn't be. It would probably just be over aroused. So that I think of in terms of PTSD, you know, which is awful, but hopefully their nervous system didn't necessarily wire itself up in a state of fight or flight. Yeah, so they still can be traumatized, they can still be over aroused, but you can probably be okay just doing calming stuff. Which, by the way, if you know this person is traumatized, no matter what age the trauma occurred, we're probably not going to start out with activating, right? We're going to probably start out with calming. Yeah. So, but if their trauma happened as an adult and their childhood was pretty good, you can probably just do right side training. And we will talk more about that next week.
Great. Thanks so much, Mary.
Yeah. You're welcome. Thank you, guys. Thanks a lot. And thank you for your patience.
Thank you, Mary.
Thanks, everyone. Bye.